Okay, so welcome everyone to our very first AI medical imaging seminar. So my name is, where's the camera? Okay, yeah, I'll just sit down. So my name is Dimitri Kester. I'm a postdoc here in the Department of Radiology, and I've co-organized this with wonderful Ines Machado, who's a postdoc in the Cancer Research Institute. And the idea behind setting this sort of seminar series up was just to bring together the network of people working within the AI medical imaging space, share ideas, knowledge, and then hopefully also help anyone who is new to the space to get started. And the format of this is sort of shorter presentations, around 30 minutes, and then leaving plenty of time at the end for any sort of discussion we might have, any questions. So please put in all the questions you have online in the chat, or just unmute yourself at the end, and then hopefully we'll have a nice discussion at the end. And with that, I'll just hand over to Ines.
Okay. Yeah, so we are very excited to introduce the first speaker of this AI seminar series, Cathal. Cathal is an honorary radiology registrar here at Addenbrooke and also a PhD student under the supervision of Mireia. And Cathal's research focuses on the AI development and validation AI segmentation tools for ovarian cancer on CT scans. So yeah, Cathal, just maybe to you.
Thank you.
Welcome.
Thanks, Dimitri and Ines. Should I try and get rid of this thing in the corner? Maybe minimize
you can make it closer. Yeah.
Cool. Hi everybody. Apologies to people who've already seen this talk. That's almost half of the audience. And thanks everybody online for joining. So thank you for the kind introduction. As Ines has said, my name is Cathal, and some of you may know me from working in the departments. I used to be under the supervision of Evis, and now I'm under the supervision of Mireia. And the topic of this talk will be to talk about a novel framework for appraising the practical utility of AI segmentation models, which we have developed during the evaluation of an ovarian cancer segmentation model, which has been the work of Thomas Budden-Coates, PhD. So over the next, I guess, half an hour or so, that's enough time-wise, I'll briefly introduce the topic of ovarian cancer and why we think it would be useful to be able to segment it in a quick and robust way. I'll then pivot to talk about how we assess the quality of AI segmentations generally. So kind of the status quo ways in the community to do that at the moment. And then we'll talk a little bit about whether actually those evaluations actually translate to clinically useful tools. And then we'll finish by just kind of some final thoughts and perhaps then move into a discussion. So high-grade serous ovarian cancer is the sixth most commonly diagnosed gynecological cancer in the world, and it's the most common cause of death from cancer of the reproductive system in women. So from a UK perspective, each year there are about 7,500 new cases diagnosed, apologies. And unfortunately, the majority of those cases will be diagnosed at an advanced stage. And that makes, that's very important because if we can pick up the disease early, then we can actually have a curative outcome in most patients. But sadly, advanced disease is characterized by many recurrent bouts of disease, initially responsive to chemotherapy, and then slowly becoming non-responsive to chemotherapy. And ultimately, most patients in this situation die of bowel obstruction. So the really challenging thing about ovarian cancer is this very unique biology, which is that, first of all, I should say that the term ovarian cancer is a misnomer. So the disease actually doesn't originate from the ovary, rather it originates from the distal end of the fallopian tube, so the fimbriae of the fallopian tube. And what happens is we get this transition into carcinoma, and these cells are then exfoliated off the surface of the fallopian tube. And unfortunately, what happens then is that they're carried on the natural flow of peritoneal fluid around the abdomen, and they seed into different locations. And the really, really challenging issue is that each of these disease sites then starts to evolve slightly differently. So we get divergence in the genomic and immunological landscape. What does that mean? Well, it basically means that when you're trying to treat a patient, you're treating many subtly different types of disease. So not one disease where we can say a patient is responding and things are moving in the right direction. We can say perhaps this disease, underneath the diaphragm or on the liver capsule is responding, but the disease in the omentum is not. And we also know that there's even heterogeneity within the same lesion, so that there could actually be different disease response patterns in the same site, not just between sites. So this is really challenging. And at the moment, the way that we assess response to treatment is on the basis of unidimensional measurements from a kind of a few arbitrarily chosen lesions, usually following what we term RECIST 1.1. So you probably all have heard about it. We choose up to 5 lesions, we measure them. So we measure the longest diameter at a kind of a baseline time point, and then the patient is given treatment, and then on serial imaging, we measure the same lesion and we see if it's got bigger or smaller, and on the basis of that assessment, we can say the disease is responding to treatment or not. But for the reasons I've mentioned before, choosing just 5 randomly chosen lesions doesn't actually give us a representative idea of whether the whole disease is getting better or worse. So trying to think about better ways to assess response to treatment, we think about something like being able to segment out the disease. So if we were able to identify and clearly delineate all disease sites across the abdomen, we would be able to very quickly work out the volume of disease, the global volume of disease. That would give us a much more clear impression of whether the disease is responding to treatment or not. The second cooler thing would be that we would be able to perform radiomic analysis on those segmented areas. So we'd be able to understand on a much deeper level actually what is happening, and be able to quantify that intersite and intrasite heterogeneity in a more fundamental way. So segmentation is think about it as a pre-processing step. It's a key to opening up other doors, but at the moment, it's a fundamental step that we have to get right. And the reason why we don't do it in the clinic is because it takes a horrendously long time. So Vlad can attest to this. So this is a case that I've segmented. Now I'm not very quick, but here we go. Let's see if it plays. We need this to play because otherwise it doesn't look like what I'm doing takes any time. So this is just a randomly chosen patient, and all of these colored areas are the separate disease sites that we've just seen. So they're scattered across the abdomen, many different regions, many different shapes, and they're subtly different from the surrounding normal tissue. So it's not like maybe, for instance, kidney cancer, where when you've got a contrasted scan, it's very easy to pick out the tumor from the normal tissue. These are much more subtly different to the surrounding structures. They're much more various in size and shape. As shown here by this diagram. So these are the main disease sites that we get in ovarian cancer in terms of disease bulk. So probably 90% of the total volume of the disease is separated between the pelvic disease, which kind of falls beneath the pelvic girdle, and then the omental disease. But that's not to say that's all of the disease. There are many other discrete separate sites. And the segmentation is hard and time consuming for a human to do. So the last case probably took about 2 hours for me to do, between 2 and 3 hours. And that is something that's kind of prohibitively expensive in a time sense to do in clinic. But if we could do it, to emphasize again, we could open up these other techniques, which would be, better than our current way of assessing treatment response. Okay, so pivoting to talk about how we would assess the quality of a segmentation. So we're thinking about this from an AI perspective, all right? So just keep that in mind. So the current way that we assess whether a segmentation is of good quality or not is kind of based on I suppose, guidelines, or kind of a method that was developed after the first grand challenge in MICI 2007. So what they did at that time was they basically set a challenge. They released a data set of images with some ground truth segmentations, which were created by a human radiologist, and they said to teams, come with your algorithms. We'll release the data a few weeks in advance and see if you can create segmentations, and we'll rank them all on the basis, importantly, of this middle metric here. So they used, oh, you can't see my screen, can you? Oh yeah, thanks, Dimitri. Perfect. So they created the rankings in this grand challenge on the basis of this top metric here, dissimilarity coefficient. So this image in the center shows the most commonly used quantitative metrics for assessing the performance of segmentation algorithms in grand challenges since the first grand challenge in 2017. So you can see that by and away the most commonly used metric is called dissimilarity coefficient. And on the right here, we can see how dissimilarity coefficient is calculated. So it's what we call an overlap metric. And it basically just refers to the amount of overlap between the ground truth. So in this case, this blue square is a radiologist created segmentation of a particular object. And the orange is the AI created segmentation. And this hatched area in the center is the amount of overlap between the two. So dissimilarity basically is calculating the amount of overlap divided by the two other objects. So it's essentially trying to say how many voxels are common between the ground truth segmentation created by the radiologist and our AI generated segmentation. So this was actually developed in zoology in the 70s, and it's been applied now in medical image analysis because it's simple to calculate and simple to understand and easy to replicate. But there are a lot of issues just in the case of ovarian cancer, but these are common issues to all sorts of medical image segmentation tasks. So the first thing about DICE is that it really prioritizes pixel overlap instead of the number of objects detected. So I hope you can see this. The writing is quite small here, but basically this is our reference goal. We'll call it the gold standard. So this is being created by a radiologist, and we've asked two different algorithms to segment the same thing. And the DICE score, which is out of 100 or out of 1, so that's the maximum amount of overlap, right? We can see that this first one, prediction 1, has a DICE score of 0.92, which is really good. I'll show you the DICE scores for our algorithms later on, and you'll see how they compare. But in this case, it's only picked up the big object, and it hasn't picked up these two smaller ones, which could be very important. In the case of ovarian cancer, for instance, the supradiaphragmatic lymph node, which is really clinically important because in very severe cases, the disease infiltrates there, and it can basically signify that the disease has traversed the diaphragm, and it's associated with the mesenchymal subtype, which is a more aggressive form of the disease. And picking that up, for an algorithm to pick that up, it's really important. But on the basis of DICE, you can see this second prediction here, number 2, it's picked up the two small lesions, but purely on the basis of this overlapping voxels, you can see it's actually got a lower DICE score. So for the people who can't, if you can't quite see the numbers, so the prediction number 1 has a DICE score of 0.92, and this second one has a DICE score of 0.79, even though it's picked up the 3 lesions. I won't go into the 2 other examples in detail, but basically DICE also doesn't consider the variability of structure size. So small structures are penalized much more than large structures, just on the basis of overlapping voxels again. And the last thing to point out that's important is that it's totally unaware of shape. So all of these different segmentations have identical DICE scores, even though they're all completely different. But purely on the basis of overlapping voxels, they have the same amount. Okay. So I wanted to highlight some papers which mention this issue in the way that we currently assess the quality of segmentation. So the first paper, a really excellent paper, produced by Lina Meyer-Hein, who leads a team in Heidelberg in Germany, and they're kind of like the gurus basically in segmentation and metric assessment. They published this paper in 2018 looking into why rankings, specifically grand ranking challenges and the metrics that underlie them, why they actually don't translate to tools which actually have clinical utility. And that this was a big issue because there are a huge amount of people spending a lifetime of work trying to produce algorithms, testing them on data sets, but actually they're almost completely removed from the, I guess, clinical world, essentially. They have lots of these teams, as I'll mention on an upcoming paper, don't even have clinicians involved in their research teams. So they're purely chasing a good metric and not necessarily a clinically useful tool. So this paper is really, really useful and interesting. The second paper that I want to highlight was also including some of these team from Heidelberg. So it was a kind of an analysis of a KITS 19 challenge, which is a kidney segmentation challenge. So they produced a report after this challenge. And one of the things that they mentioned was that because they released the data set a while in advance, there was a suspicion that perhaps teams were actually cleaning their data to boost their metric result. So so trying to remove cases that DICE were penalizing so that they could artificially boost the score. So, and that because of the way that these challenges are being run, there is an element of non-transparency or not being transparent, you know, that people can essentially sometimes hide behind the DICE score. The third paper that I wanted to mention is something that some of us collaborated on last year, and it's not totally related to segmentation algorithms per se, but it was basically looking at about 2,000. We looked at 2,500 different papers that had been published relating to models which claim to be able to pick up COVID on chest X-rays and CT scans. And the thing that I want to highlight about this is that a lot of the teams who, a lot of the people submitting these models, first of all, had no clinicians involved in their teams, and secondly, because of the fact that the field often publish papers on archive, they don't go through peer review. And we found actually that of the 2,500 papers and models that we looked at, there were actually none of them that had clinical utility because of systematic issues in their study design. For instance, you know, there was shared images between the test set and the training set. Or for instance, a common thing we found was that for their normal chest X-rays, that they were that their models were very accurate at assessing as not having COVID. Those normal chest X-ray data sets were pediatric chest X-rays. So it was very easy because it's very easy to pick out a pediatric chest X-ray from a human, from an adult chest X-ray, and that was basically the algorithm's shortcut to the correct answer. And because of not having a domain expert involved in the studies, that sort of thing that would be obvious to somebody who specializes in medical imaging would have been picked up very early. And the last paper that I want to mention is this really interesting paper published in the last few months, which talks about the reliance on metrics as being a fundamental challenge in the development of AI tools generally. And so it relates to something called Goodhart's law, which is essentially that when a metric becomes the exclusive measure of utility, it ceases to become a good measure. And we see that in lots of things. So when you try and train something to hit a number, then it loses sight of the reason it's doing the task and purely chases a good number. This was developed in economics, but we can see it in, you know, a wide area of fields, and it definitely applies in the area of medical segmentation, where people are purely trying to chase a better DICE score and actually not, and losing sight of the fact that that's not the point. Rather, it's to create a tool with utility. So, so there are three issues, as I see it, that relate to the way that we develop and evaluate tools at the moment. So the first is that there is no obligation or value placed necessarily on having a domain expert involved in the development of these tools. So one of the great things about the field is that the barrier to entry is really low, but it's actually one of the big shortcomings. So Bill, who's not here, he and I have heated debates about this, because he loves the fact that he was able to download the data sets from his home in a college dorm. He was able to run the algorithms, the code of which was available freely online on GitHub, on his gaming laptop, and he was able to start generating segmentation models, which he could then test and create a DICE score for, and then say, this is how they match up to the gold standard. But when you're starting to think about tools which are then being clinically translated, having a tool which conceivably could have had no medical imaging expert involved in their development, training, testing, or validation lacks transparency. And from the point of view of getting radiologists on board with their adoption and also patients on board with their adoption, I think that that's a real shortcoming. And also not having a domain expert involved from the start obviously allows errors like we mentioned in the COVID study to happen. But also it means that people can pursue things that actually have no clinical value potentially, that are just purely an academic exercise. The second thing, this is my attempt at a corny joke, is that basically at the moment, medical image segmentation, these tools are purely being developed as standalone operators. So last week I attended a conference and there was a huge amount of people proposing segmentation algorithms, submitting to grand challenges, and they were all for tools which are standalone operators, which try and beat a radiologist. But there's at the moment, no facility or no space to actually consider whether some of these algorithms might have maximal utility as a collaborator. So helping a radiologist to do a better job. So that's the second issue, as I see it, the current paradigm for evaluating these algorithms. And the third one, which is a kind of a difficult one to explain, but I've tried to explain it with some diagrams. So basically, the issue with radiological image assessment is that it's essentially a subjective assessment of an objective truth that we can never get to. So when Vlad segments a scan, even though Vlad's segmentations are fabulous, it's his version of the truth, if that makes sense, right? And so what we're doing is, often in these studies, we only have one radiologist's version of the truth. And what we're trying to get the AI to do, because we're testing it with a data set of Vlad's scans, and we're testing it against, to see if it can attain Vlad's standard. All we're doing is trying to create tools which match human performance. But because it's a subjective assessment, it's not actually the ground truth, if that makes sense. So, you know, we could have, for instance, in this case, we have a subject, a lady, and we say, okay, represent this lady in the most realistic way possible. And so we have this picture, and then we get an algorithm. We train the algorithm on this representation, and then the algorithm iteratively creates different versions of the same thing. And at the moment, we're evaluating them on the basis of this subjective assessment of the truth. But there is no space or facility to actually allow for the fact that the algorithm might make a better representation of the objective truth, if that makes sense, because we're testing it against human performance. So sometime in the future, algorithms might exceed our ability to create good segmentations, but testing them against a human almost holds them back in a way, if that makes sense. So moving on from the way that we test algorithms at the moment, we'll talk about what we did in our study to see if we can do better. So I'm not sure who's on the line. Maybe Thomas is here. This is stellar work that formed the basis of Thomas's PhD, which he submitted a few months ago. I picked up his thesis for him. It was a cool experience. He used the state-of-the-art medical image segmentation algorithm, which is called NNUnit, and he basically used that as a starting point, and then worked on developing an algorithm which segments ovarian cancer on CT scans. You know, I mean, he's basically he's exceeded NNUnit and reached kind of like state-of-the-art performance. But the DICE score that we've achieved at the end of this study was 0.72 or 72 for the pelvic ovarian disease and 0.64 for the omental disease. So to give a comparison, the state of the art in kidney segmentation would reach a segmentation quality in terms of DICE score of about 0.97. So we're really a long way away from that. And if you're looking at it purely in black and white on the basis of DICE score, you'd say maybe this algorithm isn't so good. Now that belies the fact that the challenge that we're setting is really difficult. But maybe we thought that actually we can flesh out the bones of these numbers and actually show that his algorithm has utility. And that maybe because of that, there are other algorithms out there that have utility that is being missed when you purely use one metric to assess quality. So how we did this, I see James is in the audience, so I want to thank James. James was one of our interrogators. So basically, the first part of this study was we wanted to understand whether the DICE score of 65-ish to 70-ish, whether that actually translated to segmentations which were noticeably different from human segmentations. So that's the premise of a Turing test. So you basically want to see if a machine can fool an independent human interrogator into thinking that it's a human. And this concept was developed by Alan Turing in a kind of a paper he published in a journal called Mind in the late 50s. And we did this, and I want to give a big shout out to Lorena, who basically managed to create this wonderful graphic user interface and place where we could host the Turing test. And what we did was we created, we had basically 80 segmentations, so 40 of which were created by a collaborative radiology team of me and Ramona. So they were, I think you could probably say higher than the standard you see in a lot of radiology papers where, a lot of segmentation papers where there's only one segmenter. So we had a collaborative segmentation team. So we were already setting the algorithm a slightly higher bar. And then we had segmentations that were created by Thomas's algorithm. And we asked our group of interrogators, so we had 20 interrogators from a variety of expertise. So the spectrum went from all the way from specialist gynecology radiologists. So we had genitourinary radiologists with up to 20 years experience in imaging ovarian cancer. And right down at the bottom, we had medical students who had, I think you could basically say no experience in looking at medical imaging, aside from the fact that occasionally they'd be in MDTs and stuff like that. They were essentially, I won't say completely new, but pretty new to the field. We set them this task, and the results were really interesting. So this blue line in the middle, that represents 50%, and 50% is the level that you have to hit for the algorithm to fool our interrogators into thinking it's a human. And the reason for that is it basically equates to guesswork. So every time they look at a scan, they have a 50-50 chance. So they're essentially guessing. And what we found was that the gynae consultants were slightly better, but with a mean accuracy of about 63. They weren't a lot better. And that the medical students had a mean accuracy of about 58. And the separation was even narrower for the mental disease. And when we statistically analyzed these, we found that there was no statistical difference, and we had actually quite a large data set by the end because we had about 1,800 samples, and we found that there was no statistical difference between the accuracy of the most experienced, the gynecology genitourinary radiologist. Sorry, this phone is really annoying. The genitourinary radiologist with 20 years experience, right down to the medical students, 4 years in medical school and no specialist experience in radiological imaging. So we then started to think, okay, what's the background to this? Why are the medical students so good at picking up these errors? And we found that actually from the qualitative feedback we were getting, that the medical student, not the medical students, just generally, people were reporting that they noticed unnatural borders and that there were kind of things that didn't look like it had been done by a human. Not necessarily that the segmentation quality was horrendous or that the machine was vastly worse, but rather that there were stylistic errors that kind of gave a shortcut to the hand, pardon the pun, of the machine. So people were picking up those signatures, and we thought, okay, well, maybe actually, if we were to not be distracted by the dice score, that actually these things, these unnatural things might have an impact on dice, but they mightn't actually affect the quality. So what we then tried to do is we tried to develop, excuse me, a way of independently assessing the quality and the utility of the algorithm. So we started to think, okay, so from our segmentation point of view, what would give clinical utility for us to roll this out in the clinic? So first of all, does the algorithm reduce the segmentation time? Because at the moment, that's the major barrier towards its adoption in the clinic. And the second thing, which is a little bit more difficult to quantify, is does it affect the quality of our assessors' segmentations? So if we were to use this algorithm as a collaborator, potentially, would it augment or improve the quality of our assessors' segmentations? So the way that we did this was we chose a random subset of about 30 scans, and this was from a separate independent data set. So we used the Icon 8 scans, which Lorena and Evis Karkani, who's maybe not on the line, have been doing sterling work in recruiting. So we used these scans, and what we did for each of the scans was we created 3 versions of segmentation. So for each scan, there was 3 segmentations. The first one was created by a radiologist. The second one was automatically generated by Thomas's algorithm. And the third one, we got a separate radiologist who hadn't seen the scan before to amend the segmentation which had been created by the AI. So in effect, a collaborative segmentation. So for each of these times, and I think it's most important, we got the radiologist the first time around to time how long it took them to segment the scan, and then for the collaborative segmentation, we asked them to record how long it took for them to amend the AI segmentation. And what we did for the second step was we got an independent radiologist who specialized in the disease and was experienced in looking at these types of scans to look at the segmentations overlapping. So we put them all on the same screen together. We didn't put them separately. This was, like I said, a radiologist who has a lot of experience in looking at ovarian cancer. This was Ramona. A lot of experience in looking at ovarian cancer on CT scans. But this, I think, for the generalization of the framework, could be translated to any domain expert. So basically somebody who's got an experience in looking at the disease and is able to, in a reliable way, assess quality. And what we wanted to do then, instead of using just a Likert scale, which was totally subjective, is we wanted to make an objective scale of quality. And the objective scale is based on the errors that we see in segmentation, the main types of errors. And those errors are that there's irregularities or problems with the boundary, that there are areas of normal tissue which have been incorrectly segmented, and thirdly, that there is missing areas of disease. So the latter two are sensitivity and specificity, basically. And we have created a stepwise scale from 0 to 7, where we've included all these errors. And basically 0 refers to a segmentation of very poor quality, and 7 is a segmentation of excellent quality. And we gave this scale to Ramona and we said, consider this, use this scale. It's a prototype, see if it works, see if you need to amend it, any changes that you want to use. It's just a guide. And in the end, actually, she felt that it worked really well and that she didn't need to amend anything. And what she basically did was with these overlapping segmentations, and it's difficult to see here on the screen, but here we have a segmentation and we've kind of gone midway through the pelvis, and we've got 3 versions of the segmentation side by side. And the reason that we wanted to do it in this way is because so there's a field of research in psychology called structure mapping theory, and what it says is that by giving somebody comparisons to compare, they're actually better able to infer the salient points of quality, what matters and what doesn't matter, and actually to infer information that they can't see, if that makes sense. So I guess it kind of means that if you've got a guide when you're assessing something, you're better able to assess quality. And And that's something that kind of we think may address this subjectivity of the radiological assessment with the Mona Lisa pictures at the start, right? When you've got one person looking at a separate thing in isolation, it's difficult maybe to get a really good ground truth. But we think if you put these overlaying versions, you're actually better able to get to the point where you can see really what the truth may be, insofar as we can with our eyes, because obviously that's the major limitation. So we got Ramona to do this for each of the 3 segmentations. Sorry, this is a really important point that I didn't say. These were unlabeled. So she was looking at unlabeled segmentation. So she didn't know which one was created by the human, the AI, the collaboration. And the findings, so then...
Was he looking at the 3 segmentations of each case? Or not?
Yes, 3 segmentations on top of each other. So they were overlaid. So she was able to, they were just in different colors, and she was able to see kind of side by side which one she thought was better. She gave each an augment score, and what we did was we then basically distilled down that score between 0 and 7 into a ranking. So for each scan, we kind of said, you know, the AI or the human plus AI was the preferred segmentation. And then we also calculated an aggregate augment score for each of the segmenters. So over the whole data set of 30 scans. I'll explain this in a second, you'll see. And in addition, we obviously computed the time taken to create the segmentations. So our findings were that firstly, when we use the AI as a head start to speed up the segmentation time, we found that the time saving was over 50% for the pelvic and ovarian disease. So a really significant time saving for that. And for the omental disease, which is a little bit more technically challenging, that the time saving was not so large or significant. But overall, we have a very significant time saving of over 30%, which when we're talking about segmentation times up to 2 hours or more, this is a significant thing, both in terms of money, essentially, because you're having to pay these radiologists to do the segmentations, but also in the expediting of creation of data sets which can train future algorithms. This is an important thing. And the second, I think, thing which is maybe more interesting is that we found that actually the segmentation quality was preferred. So this is the ranking. This is the aggregate first, second, third place rankings. We found that the segmentation quality of the human plus AI together was preferred to that of the human or the AI. Interestingly, actually, the AI was the second most popular segmenter. And when we computed the overall augment score, the mean augment score for the 3 segmenters over the 30 scans, we found that the human plus AI segmenter was significantly better. Its mean quality was significantly better in terms of augment score at the 99th centile. So this is beyond the 95th centile. So it's an extremely significant result. And to essentially summarize what we're saying here is that the algorithm is allowing us to create segmentations of higher quality than we could as a human radiologist alone. And it's also expediting our creation of those segmentations. So it's a double win, essentially. And it was augmenting the quality of all 3 segmenters. So this was across a panel of 3 radiologists. Okay, so sorry I've taken so long, but what does this mean? Okay, I hope that I've convinced you that grand challenge rankings and purely focusing on a single metric is a very superficial way of assessing segmentation quality, and it probably doesn't capture the quality we care about from a clinician point of view. One of the big issues, and I tried to illustrate that through the COVID review, is that a big limitation of these studies is that there is no obligation or no reason for them at the moment to include a clinician in their studies. And ultimately, as radiologists, unless we're totally going to be replaced, we will retain legal liability for the work of these AIs. So I think for us to kind of essentially retain control and leadership in this space, it's incumbent on us to be involved in the design process from the start and to be involved in the validation of these tools from a transparency point of view so that we're comfortable in adopting them, but also from a patient perspective, because in a separate study that I'm doing, looking at patient attitude, we found that patients trust these tools through their clinician. So they don't trust the tool, their trust in the tool is totally referred from their trust in their clinician. And so that means that a clinician has to advocate, trust, and essentially sell these tools. And we can't do that if we don't actually know what they're doing and we don't appraise them. And as mentioned in the KITS 19 challenge, a lot of maybe mistruths can be hidden behind DICE scores. So we think that if we were to propose a new gold standard for how we appraise segmentation models, where we don't just rely on a single metric, a single quantitative metric, be it DICE or otherwise, but that we say, if you want to do really good segmentation work, you should challenge your model against the gold standard, which at the moment is a domain expert radiologist in whatever disease that might be. We think that that would increase transparency, and we think that that would better link the creation of these models towards a real clinical need, so that they are translated into tools that have utility in the clinic. So this is these are some pictures from the MICI conference, which I attended last week, and this is a picture of the poster, which I want to give a big shout out to Shafiq as well, who was really helpful in giving me graphic design guidance on the creation of the poster. Somebody told me it looked like clickbait, which they said was a compliment, but I'm not sure. And secondly, in the creation of the figures for the framework. So that's everything.